thank you for the opportunity to speak here today, and I especially want to recognize Kelly for her incredible efficiency in helping with arrangements to come. And I think probably all of us could say the same thing. Thank you to Kelly. Now, before I start, Dr. Del Rio told a story going to the past, so I want to do the same. Yesterday, you heard a lot about the success of programs in Malawi. Now, I had the good fortune to live and work in Malawi. I was transferred there in 1998 from Uganda, where we had already started some PMCT programs. Testing was going well, and I got to Malawi in 98. There was no PMCT program, certainly no ART, and hardly any testing. And to try to learn what was going on, I went around the country, different places, and I'll never forget going to a rural hospital in southern Malawi. It was rural but not remote, because it was right off the main highway, only a couple of hours from Blantyre. And there was no testing program, but I went to the lab and asked the workers there, well, are you getting anybody coming in for testing, for HIV testing? And I'll never forget, the lab worker said, yes, we actually, last week, a couple came in and they bicycled 40 kilometers and they wanted premarital HIV testing. And I thought to myself, this is fantastic. I mean, there'd been no promotion of couples testing in Malawi. They bicycled 40 kilometers. How did this happen? So I'm always curious to know what happens, particularly when a couple tests and they get discordant results. So I sort of diplomatically asked, well, so what happened with their testing? What was the result? And he said, oh, we didn't test them. And I said, well, why not? They came 40 kilometers. Well, we only have about 6 tests in the hospital, and we feel we need to save them to test blood that may be donated when there's an emergency. So we don't test anyone else. So that was only 15 years ago. And if you remember all that you heard yesterday about what Malawi is doing, the progress has been remarkable and rapid, not only in Malawi, but in other countries. You've seen cascades, you've seen pyramids. I'm going to show you some boxes. We can move. There are many ways that we can test people. And we know that HIV testing and counseling has many benefits: earlier diagnosis, better links to care, and better links to prevention. But what does universal testing really mean? And we need to have a balance between support for greater and earlier access to testing, and at the same time an emphasis on quality, accuracy, and human rights protection. So I just want to remind you that WHO emphasizes the 5 C's of consent, confidentiality, that there should be some counseling or at least health education, that the results should be correct, and that there should be connection to care, and the testing should not be mandatory and certainly should not be criminalized. Now you've heard, just in the last day, I've heard lots of presentations with lots of different initials: VCT, PIDC, community, blah, blah. So WHO is really now recommending that we just use HTC as a standard term: HIV testing and counseling. WHO has issued quite a bit of guidance on HIV testing and guidance back to 2007. I think many of you will remember when WHO issued the first guidance on provider-initiated testing and counseling at health facilities. And they've issued many other guidelines, including most recently, just a few months ago, on planning and implementing home-based testing. Now, in 2013, in addition to the ART guidelines that you heard about from Meg this morning, there will also be guidelines issued by WHO on adolescent testing and care. And in 2014, we hope to have guidance on self-testing, and I'll talk about that more. So in the guidance that WHO issued in 2012, there really is a change in the dialogue from caution to urgency. There's quite a bit of increased testing in low and middle income countries, up to, we don't know the numbers yet for 2012, but estimated 107 million in 2011. This is low and middle income countries, and you'll note that it does not include China, which tested about that many in 1 year in one country. Many health facilities are offering testing, and more pregnant women globally are accessing testing. So a lot of good news. But we have some gaps. Although there's high acceptance of testing in antenatal care and TB clinics, it is not sufficiently adopted in other clinical settings. Amazingly, you can go to many STI clinics in Africa. They are not doing routine HIV testing. They refer people. Outpatient departments similarly often do not provide testing, and we know that clinics for children, immunization, under 5 clinics, testing is not routine. But I want to remind you that health workers are already overburdened in many countries with urgent medical problems, and HIV testing is an elective procedure in most situations, so when they don't do it, it's somewhat understandable. But we need to remember that testing in clinical settings does not adequately reach children, adolescents, men or key populations, so we need diverse approaches for universal access. Now, I took this picture in rural Kenya. This is community HTC on wheels. This was before treatment was widely available, but you can see huge numbers of people were attracted to mobile services. So what do we know about community-based HTC? It's been offered 15 to 20 years experience in some countries. It removes logistic and social barriers. We usually find when testing is offered in community settings that there's improved access for men, adolescents, sex workers, and other key populations, and certainly for rural populations. We can also do targeted mobile and outreach testing in low and concentrated epidemics. Vietnam, Cambodia, Thailand, China, India have all done this. And we can also really promote couples and family testing through home-based testing, through the index patient, door-to-door, centers, ANC, and generalized epidemics. But we've certainly learned that we need to promote all forms of testing, including couples. This is a picture from the Zambia promotion of couples testing, which really had quite a significant impact on increasing utilization of testing by couples. Now, there are many campaigns that countries are offering. South Africa had a massive campaign for 2 years. Over 13 million people were tested in a 2-year period. 2.2 million were identified to be HIV positive, and high rates of enrollment in care, good results for prevention of mother-to-child transmission, and many other prevention services were offered through this campaign. There have also been multi-disease approaches and campaigns where you do HIV testing plus, and they've included TB screening, malaria prevention, safe water, blood pressure screening, and we learned just earlier today, even diabetes screening. There is some concern that people may just line up they've already been tested, they don't need an HIV test today, but they agree to testing to get these free items. So it's something we need to think about. And multi-disease services can certainly be integrated into many forms of testing and home-based care. And integrated services have been offered for some years in countries, including primary health care, family planning, and HIV testing for nomads in northern Kenya. And I'm pleased to tell you this young man who's the camel driver, he was also trained as a counselor and tester. So we can expand, we can do a lot with community-based testing. However, there is a concern, an increasing concern, I would say, that as we're doing this massive expansion of testing, that accuracy may be compromised. There are reports of significant differences between the rate of positivity found in programs compared to surveillance data, with some suggestion in at least these countries, probably more, that programs may be missing. There may be a high rate of false negative results. So women who are infected, who need the services, are being missed through inaccurate testing. And field observations have really found that standard operating procedures are not being followed, and quality control, quality assurance processes are not universal. Now, most programs, particularly in Africa, are now providing confirmatory testing for those who test positive on the screening test on the same day, by the same tester, on the same sample. And to address accuracy concerns, there's some interest in moving the confirmatory testing to ART sites with a new sample, different tests in a different reader. And we think that this could have the potential to improve accuracy of the screening results by reducing complexity, certainly improve the accuracy of the final results given to the client or patient, and may facilitate immediate enrollment in care. So as we expand testing, we need to just remember that we have to focus on quality and accuracy as much as quantity and coverage. And particularly for all of you who are working on ART services, anyone enrolling in ART should be retested with antibody testing as the first thing as part of the eligibility process. So what are some of our future priorities? Continued task shifting. We need to make HIV testing routine in health facilities. We need to expand community testing, promote it more. More emphasis on disclosure and partner notification, and we do need WHO to issue some updated guidelines on disclosure and partner notification. And we need to think about self-testing, which is really the ultimate task shifting. So what is the situation now? We have two things happening simultaneously. On the one hand, unsupervised self-testing with tests that are not approved for self-use, that are not packaged for self-use, are being sold. You can see this headline from a Uganda paper. And we have a very good model, again from Malawi, of a research project where there's supervised self-testing, where a community health worker instructs both individuals and couples on how to do a self-test, gives them the test for free, and then asks them to return. When there's been a very high rate, something like 89% of people who take an oral test come back to the community health worker to discuss the results. So there are two models. Obviously, we want to promote more a supervised approach. And we recently had a meeting in Geneva on the legal, ethical, gender, human rights, and public health implications of self-testing, scale up. Our discussion, obviously, there's a potential benefit of self-testing with an option for those who are now avoiding testing services. Couples may be able to use testing for prevention. And certainly there's probably a considerable benefit for repeat testers and those who've already received counseling. So window period repeat testers, the negative person in discordant relationships and key populations, and it may reduce the burden on existing services. However, there are potential risks, including inadequate regulatory controls, failure to understand or follow the instructions, inaccurate reading. We don't know how many people, if they do it at home, if they test positive, will go somewhere for confirmatory testing. Right now, the currently approved oral test has a low sensitivity when it's used by self-testers, so that's of concern. And obviously, for first-time testers, there's no counseling, no referral. There is also a concern about social harms, that there could be coercion. For instance, a small businessman could buy to self-test, take them to the workplace, and insist that everybody that they employ get tested, and then negative outcomes for those who test positive. So there is some concern of social harms, and there's a concern that people may just do repeated self-testing instead of actually reduce their risk. So to summarize, HIV testing and counseling is widely adopted in health facilities in many countries, but continued expansion is needed, and we need to particularly pay attention to children, adolescents, young men, and key populations. Community-based testing is also widely accepted, and self-testing is promising, but we need some caution regarding accuracy. And we have continued concerns in general about testing services, that we maintain accuracy when there's a scale-up, that we encourage a disclosure both to sexual partners and if people are doing self-testing, that they come and disclose to health workers. And we need to continue work on linkages and enrollment in care. So thank you. I want to acknowledge Dr. Rachel Bagley at WHO, Miriam Tegmeyer, who's worked tirelessly to expand testing and counseling in many countries. And in particular, I want to thank literally the thousands of counselors who've shared their wisdom. Thank you.